So good evening. I just, want to thank everyone for joining us tonight. I'm excited to talk about one of my favorite products from NuSmile, and that's their Zirconia crowns. And bear with me, there's a lot of slides to get through, so I might be talking a little quick. But some of my own background and experience with them. We've been offering Zirconia crowns in our office for the past 10 years. I did mostly strip crowns in residency. I did some in private practice, but unlike residency, with more follow-up, I started to realize that um, there had to be a better, more efficient, longer lasting option than doing strip crowns. So I started taking some zirconia workshops, kind of began my journey. And it's been about 10 years now. I've placed a bunch of different brands of zirconia crowns. And over that time, probably done about 5 to 6,000 zirconia crowns. So I got a lot of experience on it. And in the end, I've been the most satisfied with NuSmile, and we'll kind of go into more of that as this lecture goes on. Let's see. So this is my family. That's been married for 17 years in April. Um, got one son, Tom. He's six. He's six. My daughter's Mila. She's 4. We are based out of Amarillo, Texas. Grew up in Dallas. I'm a partner in a multi-specialty, multi-office group. We've grown it to 5 locations. We got a triple HC certified ambulatory surgical center. There's 7 pediatric dentists, full-time orthodontists, 2 part-time orthos, and an oral surgeon. And then these are my 2 business partners, Dr. Ross and Dr. Cooper. Dr. Ross is an orthodontist, and then Dr. Cooper on the right is a pediatric dentist. Got my bachelor's and master's in neuroscience at Tulane. Took the MCAT. Plan was to go to medical school and be a neurologist. That's what my dad did. Katrina kind of changed my plans. Started teaching math and science in Marrero, Louisiana, and then just kind of found my way into dentistry. And then went to Texas A&M dentistry, and then went to my residency was at Children's National Medical Center, DC. Let's see. As I said before, I've been doing zirconia crowns for about 9 years. As I said before, I mostly did strip crowns and some porcelain fused and metal crowns in residency, and then in private practice, did a little bit of both. But let's go ahead and get more into it. Disclosure: NuSmile has provided financial support for this presentation and materials for the practical training of pediatric dentistry. Some images in this presentation were taken by fellow NuSmile clinicians and are credited. I would do this for free. I truly just like talking about the product and the subject. So this is all my honest, true opinion on here. Real quick, this is all very straightforward to us. It's just going through the AAPD guidelines for when we do full coverage restorations. I'm not going to go through this too much detail because all of you here are very familiar with the reasons why we do them. Types of full coverage crowns. Of course, you have stainless steel crowns, open face crowns, pre-veneered crowns, monolithic zirconia crowns, and then pedo jackets, strip crowns, polycarbonate crowns. As I said before, done plenty of pre-veneered crowns, which I think they're very functional and they work well. They're just very opaque. They're not very aesthetic, and they look like chiclets. So we've gotten away from those. We've gotten away from those. Stainless steel crowns, we still see those in the Panhandle of Texas, not from us. And then, yeah, still see plenty of people are doing strip crowns. I actually had to look up what a pedo jacket was. But yeah, ultimately, some background on all of these. I'm sure everyone here has worked in a few of these, but in the end, I do think the best thing you can offer your patient is just a monolithic zirconia crown. And just a nice example of a case from Dr. Matt Lucero. This was immediate post-op in a GA setting. Very aesthetic, minimal damage to the gingiva, very nice. Let's see. So now we'll kind of go through advantages, disadvantages. So of course, advantages like we've been talking about, very nice aesthetics. It's very most soft tissue compatible crown. There's no metal show, of course. They're durable. I have used them in multiple anterior crossbite cases, and I haven't had an issue with any of them. No nickel, of course. You're getting full cover protection, and then minimal chair time. Of course, with practice. The biggest thing here is practice is going to make perfect. It's real important to make sure you're doing good case selection when you're doing these cases at the start. I'd recommend, don't pick a case with crowding. Don't pick a case of space loss. I'd probably avoid cases with pulpal involvement. And of course, yeah, you're looking for patients with really good behavior. Um, Take your time, learn the prep, learn the fit before attempting more difficult cases. Um, you'll never be able to do it as fast as SSC in the posterior, but you can get to a point where you're very confident in doing the zirconium crown and confident in recommending it as an option to a parent. Um, Either way, we'll get more into options of first times to try things, some advice. Let's get back to it. Autoclavable. They say you can see some color change with them if you over autoclave them. I haven't seen them, but that also has come with a lot of practice of feeling comfortable with the sizing of them. No artifact and imaging for special healthcare needs patients. Disadvantages, there's no crimping. So yeah, your prep's is gonna determine if that crown fits correctly. You gotta pay attention to your saliva and hemorrhage control, and of course the learning curve at the onset. And then yeah, some people would say cost. I personally don't think it's a big disadvantage because once you place it and you place it well, you usually don't ever have to touch the tooth again until it falls out naturally. Oh, also with cost too, because usually people ask at the Q&A, we charge about $100 more than we do for our SSC code. Yeah, so the crowns come with their notations on the back of them. I personally do polish them off. Um, I just I've had associates that haven't done it, and I've had parents complain, even though it's very hard to see and it's like half of it's subgingival. But so I go ahead and polish them off every time. I just use a white stone, very simple. So what is the relevance of gloss on zirconia surfaces? So the key point here, NuSmile crowns are highly polished, which results in a less plaque buildup, easier cleaning, better aesthetics, and it creates less abrasion and attrition on opposing teeth, um, as opposed to crowns that are hand glazed. And we'll discuss more of that later. A lot of other brands are using hand glazed. Also, the zirconias are highly biocompatible, like we talked before. It's been confirmed by numerous studies, makes it an ideal material due to its minimal adverse tissue reactions. These look wonderful on follow-up, even post-op. But yeah, here's a good example. You can see the plaque build up on the natural teeth and on the SSCs, but not the zirconia crowns. So yeah, it's just a great example of that high polished surface not allowing plaque to build up on there. So how strong is zirconia? Um, Anyways, the studies show that zirconia exhibits significantly superior flexural strength compared to natural tooth enamel, making it highly durable for restorations, but potentially more abrasive to opposing natural teeth if not properly polished. That's why NuSmile puts so much emphasis on having a highly polished finish. Here's another study, but in this study, basically before and after the cyclic fatigue testing, NuSmile crowns maintain a maximum fatigue load well over the maximum biting force of a child. So more support to the strength of the crown. These hold up really well, really, really well. I've done other zirconia crowns in the anterior and the posterior, again, that are hand glazed and use different like techniques for manufacturing where I have had a lot more fractures with them, which can be very frustrating for you and the patient. What about the wear to opposing primary teeth? Basically, this study showed that NuSmile zirconia crowns opposing natural primary enamel maintained a normal wear rate equivalent to natural primary enamel to natural primary enamel. So, only times I've seen very noticeable wear on zirconia crowns is when you do leave them in hyperocclusion, which, you will make that mistake when you're first learning how to do these, or sometimes when all the canines are crowned and it's left in hyperocclusion. Um, One advice I'd like to tell people, if you do end up in a situation where you've cemented a crown in the posterior and you've left the patient a little bit in hyperocclusion, you know, the crowns are pretty forgiving. You can smooth a little bit off the crown itself to help with that. And more importantly, even if you need to, do an enamelplasty on the opposing tooth, um, and you'll fix that occlusion very easily instead of having to cut the crown off and start over. So good little tip when you're first throwing on these. If you're that close to getting it perfect, then your occlusion's a little bit off. So just little enamel fixes it right up. And yeah, so this is kind of talking about the manufacturing process that I was talking about earlier. So this one's a little long here. But basically, when you're comparing injection molding and milling as manufacturing techniques for dental crowns, injection molding offers several distinct advantages that enhance precision, efficiency, and clinical outcomes. Um, Basically, by doing the injection molding technique, they're able to have a cervical margin that's only zero point 0.2 millimeters thin in the NuSmile crowns, which basically promotes the better gingival adaptation and aesthetics compared to the thicker half millimeter margins typically found in milled crowns, um, which can compromise fit and increase the risk of plaque accumulation. Additionally, injection molding ensures exact uniformity across all parts, facilitating reliable trying crowns and consistent results, whereas milling suffers from burr wear that makes controlling uniformity challenging, potentially leading to variability and rework. Um, but yeah, so NuSmiles are molded crowns, which gives it a lot of benefits as opposed to a lot of the milled crowns that you'll see in the market. And yeah, we'll keep going. I'll talk more in a little bit. Okay. One thing NuSmile does is it utilizes an internal surface treatment that mimics sandblasting to maximize the surface area, which enhances the mechanical retention for stronger bonding without compromising the crown's structural integrity. Basically, thus you're improving durability and clinical performance in these restorations, as opposed to the retention grooves you'll see in other products. Yeah, and a lot of this I didn't know all this research and all these techniques that go behind it because the a lot of the zirconia crowns I was using before we were doing lots of recements. Some of those from hyperocclusion, a lot of those from trauma. And the nice thing's been, since we have switched to the NuSmile crowns, it's been very rare, and a lot of these crowns are just lasting even with the traumas, which has been nice because we were having to do quite a bit of recements in the past. Yeah, and this is just kind of comparing the marginal thickness. Thinner's better. Like we said before, better gingival adaptation and aesthetics. Another great visual representation here. NuSmile is on the left there. And then this is just a great example from Dr. Jorge Cassian. He's kind of showing the same tooth, but with different crowns. You can kind of see the significant difference due to the marginal adaptation from the uniform, thin, tapered margin of the NuSmile crown. Yeah, so very nice. And yeah, another great visual representation from an extracted tooth. You can just see how well that's adapted there. All right, another unique feature with the NuSmile Zirconia crowns is it does come with this try-in system. Um, and basically, what they're providing you is reusable, autoclavable pink replicas identical to the final restoration. Um, which the benefit of this is you're eliminating saliva and blood contamination risks, not compromise cementation, ensuring superior bond strength, simplified procedures, and long-lasting aesthetic results every time. Um, I don't use this now. I did when I first started using these crowns, and I did not know my sizes, and I did not know how the prep should exactly look. I didn't know exactly how the crown should fill. So I did do this at the beginning. Um, but with time, once you start learning your sizes, you don't need this because usually, more often than not, the crown size you are going to do is the correct one and or it's one off. So you don't mind just, having to run one through the autoclave. And yeah, the good thing too is they're not expensive. So if something breaks these, you autoclave them too much, you're not worried about that loss. And then they also offer IvoClean. Basically, it just effectively cleans zirconia restorations by removing contaminants like saliva and blood for optimal bonding strength and long-term success. I haven't personally used this myself, but it probably would have been really helpful in the beginning when I was still trying to learn my crown sizes very well. It probably helped me be a little bit more efficient. But yeah, I think it's a great option when you're first learning how to do these. Let's see. Yeah, so here's a visual representation of the trying crowns. This is not a personal case. Um, I personally think on that last one where you can see the D, F, and G fully seated, I do think E is not fully seated. And if this was my particular case, I probably would have smoothed a little bit on the mesial of F Like I said before, the crowns are very forgiving. So yeah, if you have the crown, everything's fitting perfect, this one crown won't sit down and your incisal edges are off. My first option would be to just smooth the mesial, and then that E will sit all the way down. Um, let's say you're doing this with nitrous and you get a really big time crunch and you're losing the kid really quick. Again, these crowns are forgiving. You could probably smooth off that incisal like half a millimeter on E and just make it a little bit more aesthetic appearing, and it'll hold up just fine. So just keep that in mind that if you are in a time crunch and the kid's starting to lose behavior, there's little tips, little tricks you can do to mask maybe some mistakes you made during the procedure itself. Next, what to use for cementation? There's no wrong answer. There's plenty of options. It's really but just finding out what works best for you and gets the best results and clinical successes. Um, there's a bunch of different types of cements. I personally um, use a bioactive resin cement. I used to use Activa, which is very similar to Biosim. I since switched over to Biosim, getting the same results. Um, but let's see. But yeah, so anyways, the biosim, anyways, these bioactive resin cements have impressive bond strength. It's stronger than glass ionomers, even stronger than resin modified glass ionomers. So it is, I think, the best option. It's what I use. I personally like to cement my crowns one at a time. Some people like to do all of them at one time, but I prefer doing one at a time and having full control of where that crown's located while it's being cured, and I'm able to clean that cement off a lot easier. I think it's a lot harder to clean the cement off when you cement all the crowns at one time. But of course, it's finding what works best for you. But yeah, this is basically the same way I do mine. Gonna fill up this use your biosim or whatever product you want to use, fill up the crown completely. I like to fill it up all the way. And then I like to hold it down with my finger, rest it in the correct position, and then I'll have my assistant cure fully from the front. As they're about halfway through that cure, I'm going to use my Explorer and pull off that cement collar, and then they'll go to the lingual of the tooth. They'll start cementing from the back, and again, halfway through, I'll use my Explorer and pull that cement collar off. That's going to work really well for you every single time. Um, if you're cementing, once you cemented all four in the front, for example, if a lot of times I do like to dry everything really well and try to look for any excess cement you might have missed, because you'll be surprised sometimes where you'll find cement that you couldn't see with your eyes before you dry it. Let's just see. Let's go here. Yeah, again, as discussed before, I would recommend trying a posterior zirconia crown on a cooperative patient. What I would probably recommend doing, and what I kind of did in my first few, find a really cooperative 6 to 8 year old. Maybe a patient you were considering doing an SSC or an MOD on like on a second molar, and don't charge the parents the difference and say, "Hey, I got this great new product. It's got a superior aesthetics, and I'd like to try this out with your child if you don't mind. Don't charge them the difference, and it'd be a good option for learning how to do these crowns. And of course, if you have access to general anesthesia or sedation, that's obviously a great opportunity to practice doing anterior and posterior as well. And yeah, I do anterior, posteriors. I do everything, with nitrous and in general anesthesia as well. Um, Youngest patient I've done D, E, F, and G anterior crowns on was a 23-month-old. Um, yeah, I told them I'm always willing to try, and mom wanted to try. And even though we just did like, an exam with the patient standing in the room, but yeah, it worked out really well, and she was perfect. So once you have, just be confident, and you'll be surprised at how much you can get done, especially with just laughing gas. Real quick, yeah, we'll kind of go through the anterior express preparation guides. This is a great way to do your first couple to kind of learn what the prep looks like correctly, what the crown should feel like. And then as you learn and adapt, you can figure out your own way of doing it. I'll show you guys how I do it after all this. But to start off, we'll just kind of talk about the good, like, the NuSmile recommended way of doing these things to make sure you get the prep exactly how it should be so the crown fits perfectly. But yeah, so the Express Prep Burr kit comes with 3 burrs. You got a black stripe diamond for the super gingival reduction. You got a green stripe diamond for the subgingival reduction, and you have your football diamond for the cingulum. First off, you'll do your incisal depth cuts. Use the base of that black strip diamond, which is approximately about a millimeter. Do two, do three, whatever you're comfortable with. That's your first step. Second step, facial depth cups, just like we did before, but you use the tip of the black streak diamond instead of the base, and that's approximately about a half a millimeter. Again, two, three, whatever you feel comfortable with. Next, you'll take your interproximal slices, 1.5 times the diameter of the tip of the black striped diamond. Again, approximately about a 1 millimeter. Next, you'll level out those depth cuts, around the facial, around the lingual. Don't forget your interproximal line angles. Round everything out and get rid of those depth cuts. Boop. There's your collar. Go ahead and get rid of that cingulum with that football diamond. And then you can go ahead and test the fit with your try and crown. Next part, you'll remove the shoulder. So you're going to use that green stripe diamond. And you're going to go subgingival, and you're going to feather out that edge completely. This is probably, the big mistakes a lot of people make is don't be shy. Get subgingival. Make sure you get rid of that whole ledge. You're not going to do that much damage to the gingiva, and all heals and adapts really nicely. You don't want to leave an edge behind, because that'll make your seating the crown much more difficult. And almost basically you're not going to be able to. You got to make sure you remove all the ledges. And of course, you're always doing everything at the long axis of the tooth, parallel to the long axis of the tooth. Do not taper it toward the center. You don't want to create a pulp exposure. Not a fun day for anybody. And then yeah, you'll remove the final test fitting, and you got yourself your anterior crown. Next, we'll kind of go through your posterior express prep technique. Again, this is a great way to do your first couple. This will ensure you get a correct fit. Once you actually understand the prep, then you can kind of do it your own way. Same burr kit, which is great. First, reduce the buccal and lingual cusp to depth of central groove, maintaining cuspal inclines. Just using that tip of the football diamond. We all know how to do this. Reduce the central groove, using that football diamond again as well. Reduce the buccal and lingual occlusal thirds of the clinical crown. I'm going to show you guys how I do this, and it's save you a lot more time. Next, you can do buccal and lingual depth cuts. Again, as many as you feel comfortable with. Tip of that black stripe diamond for that 0.5 millimeter, just like we did for the facial and lingual and the anterior crowns. Next, you got your interproximal slices, same measurements as the anterior crown. Then you're going to level everything off. Again, make sure you're going around the facial line angles, the facial lingual surfaces and your interproximal line angles. You're basically just you're just running it around constantly, a couple times. If you don't think you've got enough, just keep going. Essentially, what I tell people, and we'll talk more about, just remove the enamel. If you remove the enamel, you're going to be fine. So that's the guide that I use. That's the guide that I tell most people to use. Just remove the enamel and you should be fine. Make sure you're subgingival. Don't make it any harder than it needs to be. Yep. So yeah, now we have the shoulder here. So test fit that trying crown, and now get in there, get subgingival, and remove all those edges. Don't be shy. And then you got your final test fitting. So now I'll kind of go into how I like to do it. I only use 2 burrs. So basically you have the black diamond that is similar to the super gingival black diamond. I'm using this for all the interproximal reductions. I'm using it circumferentially. I'm using it with my subgingival cuts. And I'm using the wheel for the occlusal, the incisal, and cingulum reductions. We're all working on pediatric patients. It's great to be efficient, and this cuts out a lot of steps. But again, I would recommend using the guideline for your first few, and then once you feel comfortable, find out what works best for you. This is what I found worked great for me. And yeah, the biggest thing is, you got to believe in yourself. You must challenge yourself and practice to improve. Confidence is key. This is just a couple examples that, you see in all the pedo groups and stuff on Facebook. Here's one. I despise back-to-back zirconia crowns. I don't like any posterior crowns. We don't do them at all. Don't do them. I tell parents one closer in front in the white only because it's so annoying. it just takes practice and confidence, and it is definitely something that you can master and become great in. And it's a great um, restorative option for your patients. And the nice thing too about the zirconia crowns, like you don't, for especially for the posterior, you don't have to upsell these to parents. I don't even do it. I give parents the option. I don't care what they pick, but I tell parents silver, white's up to you. I don't care. And before you even finish that sentence, they're gonna let you know they want white. So yeah, it's a great thing to offer your patients. Let's see. But yeah, so I think the biggest thing is case selection, especially when you're first starting. Like set yourself up for success, and set clear expectations. So if a pulp's going to be involved due to decay, ask yourself, is this the best case to be learning on? I would recommend avoiding pulps for now while you're learning the technique. Um, I don't personally shy away from it now, but I'm very comfortable with it. And for me personally, unless there's decay leading to the pulp, then the zirconia prep itself will not cause a pulp exposure, even in the posterior, unless, there are a few times where you have those first molars with a very high pulp horn. So make sure you're looking at that x-ray. If you do have one with a high pulp horn, have that conversation with the parent. And a lot of times in those cases, when I do have those unusual high pulp horns on the first molars, I'll no charge the pulpotomy. And I'll discuss that with the parent if that's something you still want to do. If you don't want anything in the nerve, well, then we got to do an SSC. So have that discussion, look at your x-ray, again, set yourself up for success. Zirconia versus SSC. So personally, so if I'm unsure of how the patient will do, maybe they were a little, F3 for the exam, maybe they struggled a little bit with the x-rays. I like to set the expectation with the parent first. Are you okay if we switch to an SSC if the behavior starts to go south? Good example I have, our CRNA, his 3-year-old daughter needed, I think, 3 or 4 crowns and a couple of fillings. And, we had this conversation before and, easily could have finished it if we did SSCs. Definitely wasn't going to happen with zirconia crowns. Um, and yeah, they had talked beforehand. They had agreed that if she couldn't do it, they would do general anesthesia. He really didn't want to do that, but, called his wife in the middle of it when things were going south, and she wasn't going to budge. So yeah, we did general anesthesia in that case. But it's good to have those conversations beforehand because you don't really want to be having them in the middle of the procedure, especially if the behavior starts to go south in you, and you still want to get that SSC done. Um, let's see. Yeah, and I always like to clarify too, even if dad brings the kid in and says that silver crowns are cool. I always say, you want to check one more time to be sure? Because I've also had cases where mom called in the middle of the treatment, Rise were submitting to SSC, and dad's like, yeah, silver's fine. That's what I had. And mom was like, absolutely not. So yeah, then we're cutting that one off and then putting a white crown on. But that kid was great, so it worked out fine. Um, Definitely avoid cases with crowding to start, and or space loss. But like I said before, the zirconias are very forgiving. So as you get more comfortable, there's a lot of like little tips and tricks you can do in those cases. I talk a lot more about that in the mastering class. Um, Behavior management, again, like I said before, just set clear expectations. Um, and if you have to, make sure parents understand like, hey, I can get this done if we do the silver crown. I might not be able to do the white crown. What are you comfortable with? What's our plan B? Have all those plans set up beforehand. That way you're not having those discussions in the middle of the treatment. Let's see. So just some order of operations for when I do mine. If I'm doing an anterior case, and again, this is all, well, for the anterior, this is if we're doing on nitrous. Quick 1 second of water spray. This, of course, after the kid's numb. If he's not reacting to the water, then the first thing I like to do, I'm going to use my wheel and I'm going to reduce the lingual. And if the kid's okay with that, then the next thing I'm going to do is I'm going to reduce the incisal with my wheel. Kid's still great. And then I'm going to put on that thick diamond and we're going to start interproximal cuts. And now we're committed. Now we're going to get the case done. Doing these little steps, and again, it's all very fast how it happens. Doing these steps, I don't know how many, I've done hundreds of these with nitrous. I've only one time had a case that I had to stop and I was only able to do 2 of the 4. Luckily, the kid came back and we were able to finish the other 2. Otherwise, I've always been able to do E and F or D, E, F, and G, just testing it in this little um, sequence that I like. So I test with the water spray. Kid doesn't mind it. We reduce the lingual, still fine. Reduce the incisal, that goes well. Then we're gonna go and we're gonna go quick. We're gonna make sure we get this done while things are easy and the kid's cooperative. It's not a fun place to be in if behavior goes south. But again, following these little steps, I've only once had a case where I had to or really truly couldn't get it done. But luckily we finished it the next time. Okay, as far as the posterior, whether you're doing these in GA or with nitrous, if you're planning an SSC, okay, let's say you have a case where you're doing a zirconia crown on the canine and you have a silver crown on the tooth D. Do the zirconia crown first on the canine and put the SSC on after, and then prep and do the SSC after. Um, sorry, we can prep it all at the same time, but cement your zirconia crown first before you put the SSC down. Because if you do the reverse, you put your SSC down, then you go to kind of finalize that prep on the zirconia, you're going to shred up the SSC. And like I said before, the zirconia crowns are very forgiving. So cement that first, then finish the SSC and get it fitted. Um, if you're planning an SSC on the E and zirconia on the D, I know this is one technique a lot of people like to do when they're first getting comfortable with them, and the child needs back-to-back posterior crowns. One thing you can offer is zirconia on the first molar, SSC on the second molar. I'm going to do the zirconia on the first molar first every single time. Again, they're forgiving. You're not going to shred it up if you need to, clean up your prep after you've already cemented it. So do the zirconia on the first molar, then put your SSC on the second molar. That'll help you out a lot. Okay, here's an example of a case. This was a 3.5-year-old nitrous, of course. As you can see in X-ray, D and G have mesial decay. G's a little incipient, D's maybe a little deeper. But in a case like this where kids had did decent cooperation on the exam, we're going to try this with nitrous. We don't need to do any sedation or anesthesia for this. I'm going to make it easier on myself, and I'm going to make it easier on the patient. And when I'm prepping E and F, just going to smooth off that little cavity on the mesial of D and G, make it easier for everybody. But let's go ahead and play the video.
Tell me when you're good. Yeah,
I'm good. Okay. So spraying water, kid's fine. Now we're going to start reducing the lingual. I like using isolite. I can't imagine doing this any other way. I think it's also a great way to kind of determine how the behavior's going. They can tolerate the isolite or not. Still good after lingual reductions. No. We're going to do incisal reductions now. All using the wheel, of course. Now we're switching to the thick diamond. Interproximal reductions. And you can see I'm being a little heavy against D and G there. I want to smooth off a little bit of that cavity. Yeah, and then we're going to just start getting into it. And, pretty quick here, take it subgingival and do your circumferential prep. Reduce your line angles.
Yeah, nice. You
got a thumbs up there. I like to finish a full prep on one before I start the other, but I do all those interproximal reductions at the same time, just the way I've gotten used to doing it. Real simple, nice, fast, easy. Don't make the prep harder. Don't get confused with all the steps. It's very simple. And a lot of people, anterior will be easier to learn, but with the posterior, if you just remember to remove the enamel circumferentially and go subgingival, you're going to be fine. And the posteriors, you have like a map when you're looking at the tooth. You just got to remove that circumferential enamel. I like to round the incisal edges a little bit. You don't have to do that, but I do. Doing good on time. Yeah, and so that was about less than 2 minutes. So very efficient. Now, especially if you know your crown sizes, you're going to them real quickly. This is, yeah, anyways. So yeah, you have your crown sizes. This little video is just going to show you how I remove the cement collar. See, it comes off that simple. And that's why I like to put a lot in there, because I like to have that excess, even though I'm using more material. I like to have that excess because it pops off real easy. When there's just a little bit of excess, it's a lot harder to clean up, in my opinion. But it's with this technique, overfill, not overfill, fill it all the way, put it down. They'll cure from the front. They'll go to the back. You can remove the collar. Same thing on the back. Nice big piece comes off super simple. I always like to, I always run it through, even when they're spaced. I'll always floss in between because you'll find stuff in there. But yeah, easy case, straightforward. Um, so that's probably once the child's numb, E and F fully cemented, it's probably like 3 minutes. So this is something you can get good at. It's very straightforward once you get comfortable, and it's something you can get done on nitrous in your office. Let's see, D, E, F, and G for me, start to finish once numb. And this is with iSlide in and having it. Sometimes you have to flip it. Sometimes you don't have to flip it. It's great when you can get access to all four without having to flip it. But about 6 minutes once you get real good at it.
Tell me when you get.
All right, next video. So this is oh, it's a boy. Yep, he just turned 5. He previously gone under GA when he was about 2.5 for D, E, F, and G. I think F was an extraction. D, E, and G needed zirconia crowns, and there's some pulps too. Anyways, he came back. He's got interproximal decay from the C's back. And so this case, we're doing zirconia on C and R, and we're doing SSCs on ABS, S, and T. And he actually has the exact same treatment plan planned on the left side. So I'll play this video. There are parts of this that are sped up because it's a little bit longer.
Good.
So in this case, I like to, again, like if I'm doing my canine zirconias and there's SSCs in the back, I like to start with my canines, but I'm going to do everything I can with that wheel. So I'm doing the incisal reductions, occlusal reductions on every tooth, all in the same time. And the lingual reductions. Once I take that wheel off, we're not using it again. So I'm hitting all 6 teeth right now. And sorry for the angle changes and stuff. It's difficult to film this stuff. And now we're switching to that big, thick diamond burr, starting your interproximal slices, and we're doing that circumferential reductions on the canine. Canines are great, tons of enamel. You can reduce a lot. They're very easy to prep. Now I'm going to do my SSCs, preps. I like to use a finger to retract. I feel like I have more control than I do with a mirror. So we finished the bottom. Now we're going to the top. Same thing. Did interproximal reductions. We're starting to reduce circumferentially. Kid's doing great. And once you do more of these, you'll start knowing what the sizes are just by looking at the teeth. So obviously I get all those ready, SFCs, everything next to me ready to go. All right, finishing the SSC preps. Maybe this one doesn't speed up. I think maybe it speeds up after this part. Anyway, so trying on our canines. Yep, curing from the front. Yeah, this is the sped up part. I got my Explorer halfway through that cure. I'll start removing that collar. She's going to the back. About halfway through that, I'll start removing the collar. Can never cure too much. Let me pause it right there. So one thing you'll notice a lot of times after you see your zirconia canines, a lot of the times I'll go back through with my burr and just open up that contact a little bit, just a little bit more, one more time. I do that pretty standardly. That's what I'm doing right there. I'm just giving myself a little more space for that SSC after that zirconia crown went down. Again, they're very forgiving with a little, with a little cut inside. Same thing on top. We're moving that collar. Moving that collar. Keeping things efficient. Kid's doing awesome. Run that burr again through the distal of that canine. Yeah, and then I don't feel like I had to show everyone so many SSCs because the video's getting long. But yeah, so that without the speeding up, the total prep time is about 2 minutes. And that's for Zirconia on C, R, and all the SSC prep. So with practice, you can get very quick, do everything you can with the burr before you take it off, switch to the next burr, do everything you can while you have it. And then we got one more case here. Oh, here, let's see. Okay, this is the next case. This was a 7-year-old, only having chewing pain. This is our second treatment appointment. Did okay for the exam. Anyways, we had her planned for I&J, pulp and crowns. Mom went zirconia here. So for me, in this case, it was zirconia. Like this is probably gonna end up in the pulp. So that was kind of our plan. K, we also planned an MOD. And L, we did a bigger DO. It's kind of hard to see here. H does have a little distal on it, but yeah, to make our life easier, we're just going to smooth that thing off while we're prepping I. And this video will start after we've already done K, MOD, and LDO. This one's a little longer, but it does speed up after the prepping. Actually, the prep speed up the prep is sped up as well. Um, so just did our occlusal reductions on I and J. Now we're gonna get that long diamond burr, doing our interproximal reductions.
You don't have to be real, but you put nice and good. You have amazing. You got a big size all down. I'm so proud of you.
Actually, I apologize. Right there, I'm doing my pulps. So unroofed everything, putting sterile wet pellets in there. So yeah, I like to do my pulp. So I do my occlusal reductions, then I'll do my pulps. Then after that, that's when I'll do my incisal reductions and circumferential prepping, just because I just like to have less heme, so I can have a better idea how the pulp looks. MTA, and then we're putting there we go. Okay, now we're prepping for the zirconia crown. Going circumferential, interproximal, everything's subgingival. It's a little hard to see here. It's a little hard filming the posterior ones. She did pretty good for this appointment. Again, this is her third time having treatment done. Um, she got a little upset while we were doing it. But again, she's holding still, everything's safe. Now I'm going to seat the E first, the second molar. E's a nice bigger crown usually than your D. So again, if you need to go in there and reduce anything to make space, a lot easier to take it from the second molar. Cleaning everything up. Cleaning. Submitting our first crown, first molar. Same thing, I hold it down completely all the way. See, she's getting a little upset here. Luckily, we're getting towards the end. Clean off those collars while they're curing the opposite side. Making sure there's no cement left over. Flossing in between. And we're done. So yeah, nice little case right there. Yeah, so that one in particular at that office, we have the SOAN, which we're loving. But we always like to trial everything at like our more boutique, smaller office. And so yeah, anyways, that one we used the SOAN. It was about two minutes to get numb. And you can immediately start, which is great. So considering the SOAN prep time with the MTA pulps, both the crowns seated plus doing the K and L fillings, putting the nitrous nose to taking it off. This is about 20 minutes. So real efficient, even for a child that's having little bit of, this is a little anxious, struggling a little bit through the treatment, able to get it done in 20 minutes, it's still something you can offer to the parent. So, nice little case. Probably not the one I'd pick for your first one. I would not recommend doing back-to-back zirconia crowns on your first one. Let's see. Still doing good on time. Okay, here's another example of single tooth replacement. Looks great, looks natural, wonderful result. So it's a good option if you are in one of these cases where you're going to do a single tooth, you can get good results, even when you're only replacing one. Sometimes if I have, so this kid has great shaped teeth that match the crowns really well. That's not always going to be the case. You're going to get kids that are really bad grinders, teeth are worn down. If you were to do a single crown in the front, it's going to look really goofy and asymmetrical. So in those cases, especially when they have great cooperation, I will offer to do the adjacent one for free if that's something the parent's interested in. I'll explain to them exactly why I'm recommending doing it, just so things look symmetrical, they look more aesthetic. You're paying very well for this crown. I want you to be happy with the result. And some parents are very happy about that, and definitely want you to do it. Some parents don't want you to touch a tooth if it doesn't have a cavity. But I always have those discussions beforehand, when things might not look perfectly aesthetic because the kid's grinded his teeth halfway down, or the cases where kids got. Maybe that's the time you're going to see it the most. So yeah, just have those conversations beforehand. Yeah. So fun thing, you ever get a supernumerary? We get a lot of supernumeraries here in the Panhandle. I don't know why. So I couldn't find the picture of it, but let's say you're doing 5 primary incisors, D, E, F, G, and GS or whatever. You could probably use 4 regular size crowns, and then you can use the lower zirconia crown as your 5th one. I've had ones where I've had 3 regular size crowns, and I've had to use 2 uh, lower anterior crowns to make everything fit. But so just know you could kind of play around with everything. Also, sometimes we'll have a case where you have like squared lower incisors. Again, lower incisors, I've done a couple in nitrous. A lot of times it's something probably better for a sedation or general anesthesia. Um, but if you do have one where you get squared lower incisors, you can use like the upper lateral zirconia crowns work pretty well, when they're very squared looking, just to kind of get a result that looks like how it looked naturally. Just a couple examples for the next few slides. Just a little posterior zirconia crown case. These are all like, immediate post-op. Here's anterior and posterior. Looks great. Another couple good ones. Yeah. If you have SDF on these teeth, it will cover it up. You won't be able to see it, which is wonderful. But yeah, really great finishes. Parents love it. It sells itself. Yeah, another good case here too. Again, we got SDF was applied here. Can't see anything through the crowns. It looked great. It looked natural. Looks wonderful. Very nice result. But yeah, so my top 5 tricks. Like I said before, remove the enamel. Don't make the prep any harder than it needs to be, especially in the posterior. The way I do my posteriors, again, I'm using that round burr. Sorry, I'm using the wheel. I will reduce that about 1 to 1.5 millimeters. So if you're looking at approximately at the tip of your papilla, that's where I base how much I'm gonna reduce my occlusal. I take it down to about that enamel. I leave it about, sorry, the dentin. I'm gonna leave it about 1 to 1.5 millimeters above like that, the apex of the papilla. It sounds like a lot, but you'll be surprised on how much you can reduce and not get a pulpal exposure. Um, so yeah, and then once you've done that, you're just removing the enamel circumferentially and subgingivally. So you literally have a roadmap looking at the tooth, so it's very straightforward. Yeah, keep everything nice and parallel to the long axis of the tooth. Passive fit, it's got to be passive. If you're like trying to push it, to get it just a little bit more down, so it's just right and the occlusion is going to be perfect, you probably have a ledge subgingivally, or you just need to reduce a little bit more occlusally, or maybe round your line angles a little bit more. Like I said before, don't be shy with the occlusal reduction. It's going to take time where you're going to feel comfortable taking that much off the occlusal. So, you're probably going to see a couple again that are going to be a little in hyperocclusion. Don't beat yourself up over it. You can smooth a little bit off the crown, or you can do a little bit of enameloplasty on the opposing tooth. I had a case the other day. Let's see, is K and T, pulp and crown, L and S D O. You know, for whatever reason, kid did a wonderful for the fillings, which we did the fillings first. Well, sorry, in each quadrant, did the filling first, then we moved to the crown and the pulp and the crown. Second, we started the pulp and crown, things just went south. We did it in two different appointments. Um, but yeah, dad was just mom and dad were zero interest in doing silver, so we really kind of had to push through with the zirconia. You know, I definitely left it a little higher than I felt comfortable with. Actually, we did it all in one appointment, taking that back. But yeah, so got through it. K and T, pulps seated a little higher than I would like, and the bite was slightly opened up. Left a note for myself. The kid was done at the end of that appointment. He was coming back for AB, I, and J interproximals fillings. Had him come back, wrote a note to myself, did the fillings, and just did a little bit of enamelplasty. Got that bite right back down. So just know that, there's some little tricks and stuff you can do there to make your life a lot easier. But ideally, if that kid wasn't going south on you, you could take that crown off, reduce the occlusal a little bit more, and then re-cement it. And then, yeah, as we talked before, case selection, just make it easier on yourself. You know, say you're doing a case in the OR, you know, and the parent paid for, strip crowns, whatever. Do the zirconia for free. Let them, not for free, but say don't do the upcharge. Take away the upcharge when you have good situations to practice these for your first couple. Once you get comfortable with it and you're confident with it, then you can start, just offering to parents and doing the full fee. But yeah, that's about everything. Excited to hear the Q&A and see if y'all have any questions.
Awesome. Thanks so much, Dr. Harney.
Sorry I talked so fast. There's a lot to get through.
No, that was great. Um, First question. This was in, not exactly sure which slide this was, but did you get the patient numb?
For zirconia crowns, yeah. Any video I showed you, they've all been numb before. That third case was a SOAN one. The other ones were all just traditional anesthetic. Yeah, 100%. I've never done a zirconia crown without numbing. I've definitely done composite class twos. I've definitely done SSCs with just some tack gel. But as far as zirconia crowns, numbing 100% every time. And yeah, I personally prefer the sew-in because there's no soft tissue anesthesia, which is great. And the kids really don't feel anything. It's pretty amazing. Don't have to have any tack gel, which is great. My assistants put so much on there, I don't like it. Yeah, that's a different lecture though. I would recommend checking out what do they call that one?
Next
It's like the
next question is any tips to control heme?
Oh yeah, so heme. So it's what works best for everybody. Me personally, what works for me is just cementing one at a time, and I have great success just using gauze and hand pressure. I just hold it there while they're filling up the crown. Once they're done, take it off immediately. It's seating it all. And again, we've already tried the crown. I know exactly where I want it to sit. Anyways, holding gauze pressure, they fill up the crown. As soon as I take that gauze off, we're putting that crown exactly where I want it, and they're start carrying immediately. That works well for me. That slide's got a bunch of other different materials and stuff you can use. Some people like uh, ferric sulfate. Some people like to put some epinephrine around it. I've had great success just using gauze pressure.
Perfect. Next question. Would you recommend doing opposing teeth, zirconia, and SSC?
So zirconia. Okay, I'm assuming they're saying zirconia against zirconia. Yeah, definitely. Yeah, I don't have any issues with that. Again, if you get into maybe not for your first one, but as you get more comfortable, because if you're gonna have zirconia against zirconia, you're not gonna have as much wiggle room if you accidentally leave something a little bit of a hyperocclusion. And then SSC, and then if you do an SSC opposing zirconia, no real issues there. Simple.
Next question. I don't know. Maybe they did mean SSCs as well. Would you recommend doing back-to-back crowns of SSCs and zirconia? So I guess opposing teeth and back-to-backs?
Yeah, I mean, yeah, so back-to-back zirconias, definitely not for your first one. I talk a lot more in the mastering class on doing like multiple crowns in a row.
Uh,
Um, But yeah, I mean, I don't think there's many situations where I don't feel comfortable doing either or. But when you're first getting used to these, if you do have a patient that needs a crown on the first molar and the second molar, maybe a great option when you're just starting to learn is playing an SSC on the second molar and do a zirconia on the first molar. I would seat your zirconia first. Um, that way, when you're prepping, if you need to prep any additional part for the SSC, if you got to remove any from the zirconia crown, you hit it, it doesn't matter. If you do the opposite and you see your SSC first, you're going to tear it up with the burr.
Um, any tips for placing zirconia crowns on canines? Things to watch for?
Yeah, canines. I think the biggest thing if you've got canines, check the bite beforehand. Um, I think the biggest mistake people make, especially when you're doing two or four of them, is you see a lot of people get left in hyperocclusion. Um, you got to reduce a lot more than you would think. They're a little more they're fairly narrow. So if you don't reduce like more like a good amount, you're gonna end up putting a pretty big crown on there that's gonna leave you in hyperocclusion. So you got to be a little more aggressive with the canines for sure. And that's something you learn to get comfortable with over time. The first few canines I did, I definitely was being a little more light on the circumferential reduction. And so instead of fitting like what should be a size 2 or a 3, I'm putting like a 4 or 5. And then you're just, you're totally messing up the occlusion for the kid. So that's when you learn to be a little heavier with the incisal lingual reductions and the circumferential prepping. But again, the good thing is there's a ton of enamel there before you get anywhere near pulp. So you can get pretty aggressive with the canines. So I think as you get comfortable, the canines are one of the easiest ones since there's so much enamel to work with.
Yeah,
But
great
definitely,
answer.
definitely check the bite first for the canine, always, but especially on the canines, because yeah, you can leave a kid with a pretty ridiculous bite if you don't do it right.
Uh, looks like that's it for Q&A. Give it a couple minutes and see if anybody has any other questions. Dr. Harney, I know Lurie talks about this sometimes. She'll say when she goes back, and I don't know if you happen to look at previous cases or anything like that from when you first started doing them to now, but it sounds like canines might be kind of one of those ones when you look back and you're like, oh yeah, I could have prepped more. And
Yeah, the most mistakes again, like every new associate we get, we send it to the NuSmile workshop. We wanted to get comfort for zirconia, but I mean the biggest mistake you're always going to see is just be people being shy with the occlusal reduction. Um, and not that many. Yeah. Anyways, the occlusion reduction, being too shy with that is probably the biggest mistake I see. Um, that or you have people, they're getting that crown. It's like, oh, it's so close. I just need to, if I could just push it down a little bit more, it'll be just right. But it should be truly a passive fit. There should be no feedback from the tooth. It's just sitting perfectly. It's not going to touch the tooth basically. So know that's a true passive fit. And if you're getting any like feedback, you probably just need to reduce a little bit more. Um, but yeah, I think the biggest thing is not reducing enough on the occlusal for the posterior, so you're leaving stuff in hyperocclusion. But again, if you make that mistake, if it's just a little bit, smooth a little off the crown, do a little nanoplasty on the opposing tooth, keep your life easy.
next question: have you ever had black marks on zirconia crown while using SSC on the opposing tooth? For example, doing SSC on tooth number B, putting zirconia on S. Any issues with black marks on the zirconia crown?
Yeah, I haven't noticed any, but like lately. But if you leave that zirconia crown in hyperocclusion in that case, and you don't just check the bite and you kind of leave it as is, like you'll probably find something like that for sure. And then definitely if you do canine crowns that are too big, you under prepped it, you put a big crown just because it fit passive, you'll 100% see that.
Um, can zirconia crowns be used in underbite cases?
Yeah, yeah. So I use it. I've yet to have like a end on end or like a class 3 case that I didn't do it. Um, and never really had any issues with it. Never have had any come back. Um, again, especially just, the way these ones are manufactured and the glazing they do. Yeah, even you fill it and you compare it to other zirconia crowns. These are definitely feel stronger and thicker, and you can tell that they're going to hold that better. And yeah, our re-cementation rate is way down from what we used to do with these. So I love them.
Can zirconia crowns be used on bruxers, grinders? Is there a higher chance for them to come off due to grinding?
Yeah, I feel like like it makes sense when you think about it that that should be the case. Um, but again, we have plenty of kids that come in that are bruxers and grinders, and their teeth are all, you'll have kids where they've grind down the lingual so much and the incisal so much that all you're doing is just circumferential reduction. So actually, those cases are actually really easy because all you have to do is reduce the tooth circumferentially. Um, but yeah, I mean, I still put crowns on all of them, and I haven't had any issues, which has been great. And yeah, you see it all the time. And it's quite common. If I'm doing a bunch of cases in the OR, maybe half of them, you're barely having to prep it because the tooth's grind the patient's already done the prep for you on the lingual and the incisal. So I personally
Oh,
haven't had problems with them.
yeah, awesome. Let's see here. No more questions at the moment. Again, we'll give it just a couple minutes. Anybody thought of anything else? Really, really good question so far, y'all.
Yeah, they're fun. Thank you guys. But yeah, I mean, I think the key is just to be confident, get outside your comfort zone and give it a go. Is the more practice, the more times you give yourself the opportunity, you're going to get comfortable with it. And again, the real thing, once you know the prep, once you know the fit, it's simple. And it seems like there's a lot of steps when you look at all the slides. Just simplify the thing, you'll be fine. Trust yourself, be confident. There's no reason why you shouldn't be able to offer this in your office to all your patients.